Good afternoon, everybody. On behalf of the President and the Council of Ceylon College of Physicians, I would warmly welcome you all to this session on rheumatology. Today we have three eminent speakers. All are, I would truly call, true friends of rheumatology of Sri Lanka. So I am Dr. Diminda Munidasa, President of the College of Specialists for Rheumatology and Rehabilitation Sri Lanka. And my co-chairperson is Dr. Kusala Gunasekara, consultant rheumatologist, council member of the Ceylon College of Physicians. I will hand over to Kusala to introduce our first speaker.
First lecture in the rheumatology symposium would be on early arthritis. This lecture will be delivered by Dr. Ravindra Sandhu, consultant rheumatologist, Dudley Group NHS Foundation Trust, West Midlands, United Kingdom. Over to you, Dr. Sandhu.
Hello, my name is Ralph Sandhu. I'm a consultant rheumatologist at Dudley. I'd like to thank the Ceylon College of Physicians for giving me the opportunity to talk. My talk will be about early inflammatory arthritis, and the focus of my talk will be principally about rheumatoid arthritis as part of that. Just a little bit about myself. I work as a team of 7 consultant rheumatologists and 5 specialists, clinical nurse specialists in a town called Dudley, which is in the Midlands region of the UK. This is a historic medieval town centred around a castle, which is nearly 1,000 years old. And it's very famous for its industry and manufacturing, and that's why it's otherwise known as the Black Country region within the UK. So the aims of my talk will be to discuss rheumatoid arthritis. I do realise I'll be talking to general physicians as well as rheumatologists within the audience. I'll then discuss the importance of why early referral and diagnosis of inflammatory arthritis is important, and really discuss the concept or notion of the window of opportunity. I'll then go on to talk about rheumatoid arthritis treatment, both in the past and the present. I won't be going into any specific detail, but more about the concepts of treatment and how that has changed over the last 10, 15 years or so. I'll then discuss the challenges of diagnosing rheumatoid arthritis early, and we'll present some data on our national audit on the early inflammatory arthritis service. So just briefly, rheumatoid arthritis, it's an inflammatory arthritis. It's an autoimmune condition. So it's where the body's own immune system is attacking the lining of the joints. The key area of pathology is the synovium, which becomes proliferated. And as a result of that and a consequence of that, you can then start to get erosive bony damage as well. And that can lead to extensive deformity, damage to the joints, and that itself can lead to significant impairment and disability for patients. So it's important that we assess rheumatoid arthritis both accurately and objectively. One of the reasons for this is that rheumatoid arthritis is a very variable condition. It affects different patients very differently, and also it's very much an up and down condition. Patients will often report good and bad days, ups and downs, just like being on a roller coaster. The 2 principal ways we assess rheumatoid arthritis within our clinic setting is by objectively measuring what we call the disease activity score, using a 28 joint count. And we also do a functional assessment as well. And I'm just going to discuss this in a little bit more detail now. So we just assess the disease activity score by measuring the number of swollen joints, the number of tender joints, the blood ESR, which gives an idea of how much inflammation there is, and also assessing the patient's visual analog score for global health. By doing so, we can reach a score which ranges from 0 to 10, and this can define whether our patients have got DAS remission, have mild, moderate, or severe disease activity. And by categorizing our patients, we can then subsequently effectively change their treatment, escalate or appropriately de-escalate their treatment, depending on how much inflammatory joint disease they have. We also assess, do a functional assessment. So this is really perhaps more important to the patient in terms of how the inflammatory arthritis is affecting their quality of their life and their ability to do their day-to-day activities. So this is done by completing a questionnaire, and the questionnaire asks about difficulty in doing a range of activities which are outlined in this slide here. And we can subsequently arrange a score from 0 to 3, 0 being having no difficulty in doing any of their activities, to 3 being they're unable to do their activities. So why is early referral and diagnosis and treatment important? And I'm just going to discuss the concept of the window of opportunity. So what we do know is that with early inflammatory arthritis, 70% of patients can start to develop erosive disease and bony damage within 2 years of disease onset. And studies have shown that up to 40% of patients can have erosive disease even at presentation to a rheumatologist. And indeed, within our own early arthritis clinic, we objectively measured this, and we found that 27% of our patients presenting to Dudley had erosive disease at presentation. So they're already beginning to get joint damage. We know that approaching half of patients can lose their job and their livelihood within 5 years of diagnosis of rheumatoid arthritis, and 1 in 5 can lose their job within a year. And this can have a significant burden on the UK economy as well. So really the aim of treatment is to capture patients early in their disease before any established joint damage has taken place. And what we know from a number of research papers is that essentially by capturing patients early and treating patients early with disease-modifying therapy, we can achieve much better patient outcomes in terms of degree of joint damage, in terms of achieving remission, in terms of their functional ability, than if you capture patients late when the damage to the joints has already been done. So what are the key predictors of achieving remission? 2 key predictors are, firstly, patients need to present early. And how early is that? Well, what we say is that essentially, or what the evidence tells us is that if we are able to capture patients and start disease-modifying therapy within 3 months of symptom onset, we are much more likely to achieve remission. Whereas even if patients delay beyond 4 months, that chance of remission then does start to decline. And so we want to capture patients early before the joint damage has taken place. So this has very much changed the way in which we treat our patients with rheumatoid and indeed inflammatory arthritis. So originally, I think when I started off as a rheumatology trainee back in the late 1990s, it was very much a start low and go slow approach for treating inflammatory arthritis. And by that, I mean that when patients would present with rheumatoid or inflammatory arthritis, we would often begin with they would have physical therapy and non-pharmacological intervention, followed by painkillers, principally non-steroidal anti-inflammatories. And single disease-modifying therapy was often used only people with the most active disease. So it's very much a start low and go slow approach. There have, however, been a number of seminal clinical trials in the 1990s and early noughties, and some of these are outlined here. And what was common within all these trials is that essentially they took patients with rheumatoid arthritis and treated them actively and aggressively with combination disease modifying therapy, and in some instances biological therapy as well, very much adopting a treat to target approach. So these patients were seen on a regular basis. Their disease activity was measured objectively, and if they had ongoing active disease, their treatment was escalated. The key findings from all of these clinical trials is that if we use early combination therapy with disease-modifying drugs and a treat-to-target approach, so we review patients regularly, we assess their disease activity score, we adjust their treatment accordingly, we're much more likely to achieve greater remission rates, both in the short and long term. We're much more likely to reduce radiographic progression and erosive disease and damage. There's significant evidence that improves function, functional ability for patients, their quality of life, and above all, using combination therapy and biological treatments is deemed to be as safe as well as using single disease modifying therapy. So this has very much inverted the way we approach patients with inflammatory arthritis. We will now start disease modifying therapy at the outset, often in combination with other disease modifying drugs and glucocorticoids. And if patients have persistent active disease, we can then initiate both biological therapy and the newer targeted therapies in the JAK2 kinase inhibitors as well. So this whole concept has very much been encapsulated in the Rheumatoid Arthritis National Guidelines produced by the National Institute for Clinical Excellence that were published in 2009. And very much the ethos is we, with inflammatory arthritis, treat early and treat to target. NICE have also produced some quality standards published in 2013. And essentially what these say is, firstly, for patients presenting with inflammatory arthritis to their GPs in primary care, refer urgently within 3 working days. Rheumatologists should aim to see these patients within 3 weeks of referral and start disease-modifying therapy within 6 weeks of referral as well. The key is to escalate treatment and if need be, see patients on a monthly basis to monitor the disease activity and adjust their treatment accordingly. And also it's important that patients have a comprehensive annual review because it's not only their rheumatoid arthritis, well, which can be associated with having rheumatoid and indeed inflammatory arthritis. So how can we implement our quality standards? One thing we learned very early on, even in our own regional audits, is that those units that have a dedicated early inflammatory arthritis clinic or service are much more likely to assess disease activity more objectively, review patients more frequently and escalate their treatment in that treat to target approach that I've discussed. So at Dudley, we have a dedicated early arthritis clinic. Patients can see either myself or indeed one of our clinical nurse specialists. So patients do have regular face-to-face review. They're given written educational material published by the Arthritis Research UK and indeed some of our own educational material as well, in line with the quality standards. Patients have access to a rheumatology helpline. It's also important to stress that early inflammatory arthritis, as well as the medical approach, is very much a multidisciplinary approach, and we coordinate care with our therapy team as well. Within our own clinic, we're able to demonstrate that even within a short space of time, 6 months, where patients had an average of 4 visits, patients we show demonstrable reduction in both their disease activity, swollen, tender joint, and their global visual analog scores. There are, however, challenges in diagnosing both rheumatoid and inflammatory arthritis early. Patients can delay in going to see their GP, even though they have symptoms of inflammatory arthritis. And this may be due to delay in recognition of their symptoms or feeling that they don't want to bother their doctor. GPs can also subsequently delay in reaching a diagnosis or referring on to the specialists. And indeed, because of hospital waiting lists and delays in investigations and diagnosis, there can be delays in secondary care as well. In Dudley, we have produced local materials, educational materials, and also this has occurred nationally as well, in order to highlight inflammatory arthritis and educate both patients and GPs about recognizing symptoms and referring patients early on. It's important to recognize that actually patients with rheumatoid arthritis and indeed inflammatory arthritis may not present with the typical features of rheumatoid and the diagnostic features right from day one. Patients may have a genetic predisposition with a family history. There may be environmental factors, and smoking is certainly a key factor. They may have positive autoantibodies, and indeed we do get referred patients with positive rheumatoid factor and anti-CCP antibodies. They may have symptoms, but no objective evidence of inflammatory joint disease. And indeed, they may have palindromic symptoms that come and go, or undifferentiated arthritis, but that before they go to developing an established rheumatoid arthritis. We have found that ultrasound is certainly very beneficial in detecting both erosive disease and synovitis very much before X-rays can, for example. However, this is very much in the eye of the beholder, and really having we have our own rheumatology team that carry out the ultrasound examination and compile the information they get from ultrasound along with clinical information and from blood investigations in order to get a diagnosis as rapidly as possible. I'm going to move on to the final part of my talk, just talking about evaluating the effectiveness of the early inflammatory arthritis treatment. So within both England and Wales, headed by the British Society for Rheumatology, we've been conducting a national audit, which has been very much based on the quality standards that were published by the National Institute for Clinical Excellence. The aim of this audit really is to improve the quality of care for patients with early inflammatory arthritis. It is based on the NICE standards as I've discussed, and this is an ongoing audit, and we've been collecting data for the past 2 years, and the aim is to continue to collect data for at least a further 2 years. About 20,000 patients have been enrolled thus far, and we have data for approaching 1,500 patients at 12 months. So we've already discussed this. These are the NICE quality standards, and these are the key quality metrics that are being assessed as part of this audit. So we're assessing how quick or how long does it take for patients to be referred by their GP to secondary care, to rheumatology, i.e. preferably within 3 days. How long does it take for the rheumatologist to see the patients once they've been referred and started on treatment, whether patients receive appropriate educational material, whether patients have are having a treat to target approach, as I discussed earlier in their presentation, and targets are being set and agreed with the patients, and whether patients have access to emergency advice, and whether annual reviews are taking place. So in terms of some key findings and results, we've found that about 41% of patients have been referred within 3 days by their GP. And on average, it's taking approximately 4 weeks or 28 days for the patient from being referred from their GP to be seen in rheumatology. So there's still room for improvement there. The target is 21 days or 3 weeks. About 54% of patients are started within 6 weeks of referral. So clearly there's a knock-on effect. If patients delay being referred by their GP and subsequently delay being seen, then this will have a knock-on effect in starting treatment as well. However, once patients are being started on treatment, the data has shown a meaningful reduction in disease activity, which I'll discuss now. So at 12 months, we found that really there's been a significant reduction in disease burden, as measured by the disease activity score, which I discussed earlier. And more than half of our patients were able to achieve remission at 12 months after diagnosis. And I think one of the key findings of this audit was that for those patients that were started on disease-modifying therapy within 6 weeks of referral, they were much more likely to achieve remission at 12 months than those where their treatment was delayed. So it further highlights really what we know that we should start treatment early. Targeted treatment, including biological therapy, was used in approximately 15% of patients. So a relatively small proportion within 12 months of their diagnosis. And I think this also highlights that using conventional disease-modifying therapy in combination can significantly reduce the need for biological therapy as well within 12 months. Finally, less than half of patients are having a formal annual review. And again, there's significant room for improvement for here going into the future. But we're moving in the right direction, but there's still a lot of work to be done. So in summary, the key messages I'd like to outline is that patients with early inflammatory arthritis, it's important to make the diagnosis and refer on to a rheumatologist early so that they can be started treatment as soon as possible and adopt a treat to target approach in their management in order to maximize the chance of achieving remission. We know that early diagnosis can be challenging and ultrasounds can be beneficial in making an earlier diagnosis. And finally, early intervention in rheumatoid arthritis can significantly improve patient outcomes and the chance of achieving remission. I'd like to thank you all for listening to my talk. I do apologise for not being able to visit Sri Lanka in person. I'd very much like to come to Sri Lanka as soon as I have an opportunity. I'd also really like to acknowledge and give my huge thanks to our medical training initiative trainees who've been coming to Dudley over the last 8 years, starting off with Hemantha, who came to us approximately 8 years ago, followed by Sonari, who are with my clinical director, Dr. Nicola Erb here. We've also had Amal come to us, and Madura. All have been a huge asset to our department. We've learned a lot from them as well, as hopefully they've learned a lot from us. So if there are any other future rheumatology trainees who'd like to get some international experience in the UK, would be more than happy to talk to you about getting some experience with us. Thank you very much.
Thank you very much, Dr. Ravindra Sandhu, for that informative lecture on early arthritis. Now we have a few minutes remaining for any questions from our audience. If you have any questions, please type it in the chat box.
Yeah, thank you, Rao, for that excellent lecture. Waiting for questions, I would like to ask, now we have this concept of clinically suspected arthralgia as a before getting the arthritis, where probably if we can get hold of them as well and follow up in our clinics, we may be able to start treatment early. What's your experience in UK regarding the clinically suspected arthralgia being followed up in your clinics or with GPs?
So we are encouraging those patients to be referred on to rheumatology. And I think particularly if they've got positive autoantibodies, positive rheumatoid factor and anti-CCP antibodies, there's a significant chance they could go on to develop persistent inflammatory rheumatoid arthritis going into the future. Now, we've also been involved in one of the clinical trials called the Apipra Study, which is looking at this particular group of patients. So with inflammatory arthralgia, so they've got joint pain, but no objective swelling, and positive autoantibodies. The clinical trial is involved treating them with aggressively right from the outset with a biological therapy called abatacept to see if they can go into long-term remission, in the short term, to see if they go into the long-term remission there afterwards. I think the formal results for the Apipra study are still pending, but it'll be good to know how we can appropriately manage these patients. But certainly I think they do need assessment. Ultrasound is another key thing as well that we can do to pick up subclinical synovitis in these patients as well.
There's one question from our audience. Question is, what is the place of JAK inhibitors in current practice of rheumatoid arthritis?
So in the UK, we will normally start, for rheumatoid arthritis, we will start with conventional disease-modifying therapy in the first instance. So we're guided by national rules which are set by NICE, the National Institute for Clinical Excellence. So we start off with a conventional disease-modifying therapy. And the rules we have to stick to is that providing they've had 2 conventional disease-modifying therapy and they have continual persistent active disease, so that's defined by a disease activity score of greater than 5.1, then we can move on to the biological therapies as well. Now, JAK2 inhibitors would be part of that. I think more recently, because of the COVID pandemic, there's been, this is not evidence-based, but I mean, Janus 2 kinase inhibitors do have a shorter half-life. So potentially they could be favored, but they are one option amongst several disease-modifying biological therapies that we can use for rheumatoid arthritis.
Okay, thank you very much, Dr. Ravindra Sandhu. We will now move on to the second lecture in our Rheumatology Symposium.
Thank you.
It's my great pleasure to introduce Dr. Adrian Pace, again from Dudley NHS Foundation's Trust. Why I told that they are long-term friends of rheumatology is shown by Rab's last slide. We have so many trainees ongoing, and they keep on taking them taking up trainees for long-term for their final training in UK. So, Dr. Adrian, I'll hand it over to you to start your lecture.
So, good afternoon, everyone in Sri Lanka. It's nice to be invited to this meeting, and many thanks for your invitation. I have fond memories of my time in Sri Lanka in 2016 at the Taj Samudra. I have many friends there, and many registrars of high caliber have contributed to our service here in Dudley and the UK. So, thanks again for the invitation, and I'm just going to talk to you today about the management of spondyloarthritis over the next 20 minutes or so. It's quite a lot to fit in, so I'm going to just give you a brief summary of the management of this condition. So the objects of this talk: to understand the aims of the treatment, why are we treating this condition, different drugs that are available for this condition, the different disease patterns. Very important to appreciate that the disease can present in a wide variety of different ways, including extra-articular manifestations, which are important to diagnose, to look for, to diagnose and to pick up. And then, obviously, you're trying to select the most appropriate drug for that pattern of disease that you are dealing with. So I based this talk on approved guidance, mostly from the American College of Rheumatology, European League Against Rheumatism, and there's also a touch of some personal advice and based on personal experience. I've been seeing such patients for many years, and I've developed a certain personal approach to these patients. You will be disappointed or thrilled to know that there's not going to be any graphs, no tables, no studies, and no pathways. I've got people who know me know that I've got a bit of an aversion to pathways. For a number of reasons, a number of valid reasons, I think, in my opinion. Look at this. It's a nice pathway. It's got a lot of colors, and it's a very composite pathway. However, I mean, pathways they don't always work. First of all, a pathway has an endpoint and a beginning point. So all patients have a beginning point that they enter this disease journey, but there's no end point. A patient can usually lives with these conditions for the rest of their lives. It can change from one type of disease to another type of disease. So it's not a pathway which is a fix, and the pathways generally tend to homogenize patients into one group, which is not always very helpful. It's good a pathway is good to remember things and to refer to them when you're in difficulty, but it's difficult to remember. Look what a lot of things are to remember, and unless you fix this somewhere in your room, which is useful, but you have to keep referring to it when seeing patients. I don't think it's very good. But it's the good things about pathways. We have to mention good things after all this good work here. So they're nice, very colorful, very pleasing to the eye, a bit busy, and it's also important and useful to remember things that you haven't perhaps remembered before. So the aims of treatment. I want to talk about the aims of treatment. So the aims of treatment of this condition is to treat symptoms. You have to treat the pain, swelling, and also trying to improve the function of this of your patient. And so it's also important to address complications. Most conditions are not just straightforward. As we said, there are a lot of different phenotypes of this condition, and you have to address the complications as they happen. And it's important to prevent and to reduce the end organ damage. You know, this is an inflammatory condition which results in joint damage, which results in disability. So you've got the activity of the condition, you've got joint inflammation, joint damage, and disability. So that's what the aim is, to break this circle and just to allow the patient to maintain a comfortable and independent mobility, be able to work if the patient wants to work, to participate socially, and generally just to improve the quality of life of the patient. So there are certain aspects of the treatment which are applicable to all patients, whatever type of disease they have, whatever the spectrum of disease they have, and it's common to all patients. Like you have to, in this day and age where we're online a lot, you have to direct the patient to the right resources and make sure that they're reading up reliable information. And also appreciate that you cannot work on your own. Nobody is a god. We're not gods. You need a team. You need a team, and the team consists of specialist nurses. You need a GP. You need a good pharmacist. You need a physiotherapist. You need an occupational therapist. You need psychological support for the patients and sometimes for yourself as well. And you need to advise the patient on how to access social support if necessary. Basically, to be accessible, to try and be accessible not only to the patient, and you have to be accessible to the patient, but you have to be accessible to other people who want to talk to you about your patients. It could be a nurse, it could be a GP who wants to phone you, it could be a pharmacy, it could be anyone. So it's a team approach, and it's important to be accessible to this team. So you have to appreciate also the pattern of the disease, that this has a lot of pattern. Basically, it's quite simple. There's axial involvement and there's peripheral involvement. Now, there's a lot to say about ankylosing spondylitis, or AS, and non-radiographic axial spondyloarthritis. It's quite simple, really, that if you have radiographic changes, then it's the term is ankylosing spondylitis. So if there are changes on X-rays, it's ankylosing spondylitis. If there are no changes on X-rays and there are changes on the MRI, then it's non-radiographic axial spondyloarthritis. Whether one converts to the other, whether non-radiographic is an early stage of ankylosing spondylitis, that is a topic of another discussion which is beyond the scope of this talk. But for the sake of treatment of this condition, then it's really quite the same. There's no much, not a lot of difference between the treatment of axial disease, which appears on X-ray, i.e. ankylosing spondylitis, or axial disease, which doesn't appear on X-ray but appears on MRI, i.e. non-radiographic axial spondyloarthritis. And then there's the peripheral, all the peripheral joint involvement. Lots of cases are, of course, as you would expect, and as you know, mixed, so they have some axial involvement and some peripheral involvement. And in fact, most cases are mixed cases. Remember to be holistic. You have to look for extra-articular manifestations. And a patient may not necessarily tell you about a small patch of dry skin which they have behind their ear, which could be psoriasis. They might not tell you about some ankle pain that they've had, or ankle swelling. They might not tell you about, they certainly will not tell you of some genital infection that they've had. So you have to look for these things. And when you know about the extra-articular manifestations, you'll know what to look for. Comorbidities, that's where the GPs could be quite helpful. Drugs that the patient is already on, to make sure there's no interactions with what you want to give, what you intend to give, and obviously the social setup. If you want to give an injectable drug, you have to make sure that the patient is perhaps intelligent enough to appreciate and to know when to give the drug and what side effects and monitoring drug, the importance of monitoring drugs, etc. There's also the stages of the disease. So there's an active stage where the patient needs the active intervention. Patient would go into prolonged remission, and there could be relapses, and relapses can occur at whatever time and whatever place in the body. So you have to be fully aware of this, of the possibility of relapse, and be mindful that any patient can have a relapse at any time. So these are the drugs that we have available: analgesia, anti-inflammatories, disease-modifying agents, and I want to emphasize about the terminology, the correct terminology of disease-modifying agents, and I'll be going into this again. And also there are the steroids, which have a limited place, and as I will describe later. Starting with anti-inflammatories. So which anti-inflammatory would you give? You can't give any anti-inflammatory. You have to consider things like involved gastric disease. If the patient has gastric problems, you might want to give a COX-2 inhibitor. If the patient has quite a significant risk of ischemic heart disease or cerebrovascular disease, perhaps you want to avoid diclofenac COX-2 inhibitors. You want to use something else like naproxen. My personal preference is etoricoxib. I like using etoricoxib or a COX-2 inhibitor, basically because it's effective. It's a good dosing regime. It's just once a day, and it's quite effective. And there's also been studies with celecoxib in terms of possible disease-modifying effects as well. How do you give them? In the active phase, they should be given continuously. And as we said, celecoxib may have a disease-modifying effect. Not always, but it may have a disease-modifying effect. And the disease-modifying effect of anti-inflammatories hasn't been reproduced in other anti-inflammatory studies like diclofenac, for example. So we're not sure if this is disease-modifying or not, but in the active phase, certainly it's to be given continuously. When the patient is in remission, then they should be withdrawn and used only intermittently for relapses. So they should certainly not be used long-term. Long-term anti-inflammatories have their own problems, so long-term anti-inflammatories should not be used. So this is important, the terminology of DMARDs. There are the conventional synthetic DMARDs, the ones we know about: methotrexate, sulfasalazine. These are conventional synthetic DMARDs. Then there are the biologic DMARDs. So biologics are also DMARDs. Biologics modify disease, so biologics are DMARDs. And we have these biologics, anti-TNF, IL-17 inhibitors. So these are the main biologics that we use. There are others, but these are the main ones. And then there's the targeted synthetic DMARDs, which are the Janus kinase inhibitors, which we'll be mentioning as well. So we go to the conventional synthetic DMARDs. I tend to use methotrexate and sulfasalazine only. There is some evidence for leflunomide, less evidence for leflunomide, which I tend not to use, because if you fail methotrexate and or sulfasalazine, then you'd probably be in a position where you would be eligible for biologics in the active stage. So methotrexate and sulfasalazine are the conventional synthetic DMARDs that I use. So for peripheral disease, there's more evidence to suggest that sulfasalazine is more effective than methotrexate. And you should start with sulfasalazine if you have peripheral spondyloarthritis. However, in certain situations, we have severe psoriasis, for example, that you want to manage as well. And it might make sense to start with methotrexate or give methotrexate in combination with sulfasalazine. But you want to use methotrexate for the control of your psoriasis, and maybe you want to start with methotrexate in this situation. And for axial disease, there's axial. We know that conventional synthetic disease-modifying agents are not effective. Methotrexate, sulfasalazine, not effective. There was some talk, mention about sulfasalazine being effective for axial disease. It's not strong evidence at all, but it may have its place if the use of biologics for economic reasons is not advisable. So when do we use biologic disease-modifying agents? let's start with axial disease. You have to be certain of your diagnosis. And I'm not going to go much into this, but you have to be certain of your diagnosis. There has to be no response with anti-inflammatories, and there has to be evidence of activity. So anti-inflammatories usually use about 2, if they were at a good dose for about a month. If they're not working, then and there's still evidence of activity, then you can use a biologic. And obviously there got to be no contraindications. How do you measure activity? Many ways of measuring activity of disease. The simplest way is using a subjective patient-reported outcome measure like BASDAI. Use objective CRP or MRI. In fact, if there is evidence of activity on CRP on MRI, then these are the patients that respond better to biologics. And there are combination outcome measures or disease activity measures like ASDAS, which is a combination of BASDAI plus a CRP. For peripheral disease, you have to, again, be certain of your diagnosis, and you have to have a non-response to conventional synthetic disease-modifying agents, evidence of activity in the form of 3 tender and 3 swollen joints, and again, no contraindications. Which biologic DMARDs would you tend to use? First, use an anti-TNF. Which anti-TNF? And any anti-TNF is good, except possibly infliximab, which is not really used for spondyloarthritis. My personal preference is adalimumab. Why is it my personal preference? Because I know it. I've been using it for years. And there are a lot of biosimilars to adalimumab. It's effective for a lot of extra-articular manifestations like uveitis, inflammatory bowel disease. So it's a good preference to have. There's the IL-17 antagonists. Again, there are 2 main ones. There's secukinumab, ixekizumab. Again, anyone is useful, and they're both equally the same in certain circumstances. And what's useful about IL-17, they're effective in patients who have failed TNF or even patients who are TNF naive. So now you've got the pattern of the disease, and you've got your drugs, which we've mentioned. So how are you going to fit how are you going to choose the right drug for the right pattern of the disease? And this is the challenge, that you have to know, you have to know your drugs, and you have to know your pattern of the disease. So this is, for example, if we start with axial disease, you choose the anti-inflammatories first, then you go to a biologic DMARD if they fail, starting with a TNF biosimilar usually. We're encouraged to use biosimilars in the first instance, and no place for conventional synthetic DMARDs in axial disease. For peripheral disease, you start with a conventional synthetic DMARD, use 2 of them, including methotrexate. If those don't work, then you go on to a biologic, and again, you start with TNF and use a TNF biosimilar. If there are mixed axial and peripheral disease, as is often the case, I generally tend to use the most affected component in order to get the patient onto biologics as quickly as possible. So in order to try and bypass and stop playing around with conventional synthetic disease-modifying agents. So if they have axial disease, give them 2 2 NSAIDs. If they're still active, then you can go straight on to a biologic, which is effective for axial and peripheral disease without having to use conventional disease-modifying agents. Sometimes we have to use a combination of the 2 of them. Extra-articular features, you've got dactylitis, enthesitis, which are treated more or less in the same way. There's a role of localized steroid injections. For uveitis, you have topical treatment. Anti-TNF is preferable over biologics. Psoriasis, again, topical treatment, methotrexate, as we mentioned. Psoriasis could be a side effect of anti-TNF treatment, as well as treating it could be a side effect. So if you have a lot of psoriasis, it might be wise to start with an IL-17 antagonist. For inflammatory bowel disease, anti-TNF is the starting drug. Avoid anti-inflammatories and avoid IL-17 antagonists as well, because they can exacerbate or precipitate the appearance of inflammatory bowel disease. Don't forget the treatment of other things which are important: osteoporosis, secondary osteoarthritis, sometimes secondary fibromyalgia as well, and ischemic heart disease. When you switch, do you switch biologics? If there's a primary failure, the patient is not responding at all to a patient has never responded, it is wise to change the mode of action. So not responding to a first biologic anti-TNF, doesn't make sense to give another anti-TNF. So you change the mode of action. If you have a secondary failure, the patient has started to respond, but then fails to respond, then you can use the same mode of action and another drug in the same mode of action. If you're running out of options, then change the drug, change the frequency. Not strictly allowed to do this. I do it sometimes, remembering that returning to a drug doesn't always mean retaining or maintaining the efficacy of the drug. Sometimes it doesn't work if you use the same drug second time round. Switching from a biooriginal disease modifying to a biosimilar disease modifying agent doesn't make sense. So, except for economical reasons. If you have stable disease, sometimes you get your patients who are stable and they're on a lot of drugs, start reducing the drugs, except the biologic DMARD, keep the biologic DMARD going. And you always have to involve the patient in the decision that you make. A sustained remission, people say reduce the drugs after a sustained remission without any proper definition of what sustained is. For me, sustained means years of remission, then you can start reducing the drug and perhaps keeping the biologic there. Targeted synthetic, so there's tofacitinib, baricitinib, upadacitinib. They're still being evaluated, effective and licensed for psoriatic arthritis. For axial disease, possibly. They're useful for inflammatory bowel disease instead of IL-17 antagonists, which, as we said, may exacerbate or cause the appearance of colitis. Steroids, avoid steroids except for regional steroid injection into your knee, into your ankle, into sacral leg joints. Definitely not prolonged course of oral or IV biologics. There's no evidence for the use of these other biologic DMARDs. So you have to monitor. I'm not going to go into this, but if you give a drug, you have to monitor the efficacy. There's a lot to say about treat to target, which is more reliable for rheumatoid arthritis than for spondyloarthritis. You have to individualize your treatment. I consider myself champion of individualized treatment. If you've got uveitis, for example, you have to use the right anti-TNF, use adalimumab or infliximab. Don't use etanercept. You don't use an IL-17 antagonist, which has a neutral effect on uveitis. If you've got TB, you have to select your right anti-TNF. Perhaps use etanercept rather than a monoclonal like infliximab or adalimumab or adalimumab or infliximab. If you've got IBD, use the right anti-TNF, perhaps avoiding etanercept. Avoid the use of IL-17 antagonists. Use JAK inhibitors. And there's also vedolizumab, which the gastroenterologists use. If you have severe severe psoriasis, do you really want to give an anti-TNF? Probably not, because it can exacerbate psoriasis. So start with an IL-17 antagonist. If you have CCF, demyelinating disease, recurrent infections, malignancy, it's all CCF and demyelinating, definitely don't use anti-TNF. Recurrent infections is a bit difficult because they all have side effects of recurrent infections, and malignancy as well is the same. So you have to take it on a case-by-case discussion. So conclusions and summary, you have to know your patient thoroughly, study your patient, know the pattern of disease, know the extra-articular manifestation, know the comorbidities, know what drugs are available. So you have to know your drugs by knowledge and experience, but you have to study your patient. And then use the right drug for the right patient. And if you give a drug, monitor it clinically, regularly, and tail and add as necessary. And most importantly, perhaps, involve your team. And don't be afraid to ask, don't be proud to ask your colleagues what they would do, and involve also your other team. So that concludes my talk. I hope it was useful, and I'll be happy to take any questions. Thank you very much.
Thank you, Dr. Pace, for sharing your thoughts on management of spondyloarthropathy. We have one question in the chat. What are the treatment modalities available for isolated active sacroiliitis, where the joint is only the sacroiliitis is involved? Is there any difference of treatment, or what's your thoughts?
Okay, so if you have isolated sacroiliitis, as we said, I think the first modality of treatment should be the use of anti-inflammatories. And perhaps if it's active, as the question implies, then you should use anti-inflammatories continuously. That sometimes helps. If there is isolated active sacroiliitis, then there's a role of localized intra-articular steroids for if you have someone with the expertise to do it. And so initially, I would use intra-articular steroids plus continuous anti-inflammatories. If that doesn't help, and then disease measurements indicate or suggest that these are not effective, then you can in this situation either change the anti-inflammatory to use another anti-inflammatory. So you would have used two anti-inflammatories, and if that still doesn't work, then you are eligible by national guidelines to go onto a biologic. So you have to measure your disease activity using Barrett's ankylosing spondylitis disease activity index, and then choose your biologics. So that would be my pathway.
Thank you, Adrian, and thank you very much for that lecture. So it's time to move on to the next lecture. I'll hand over to Kusala again.
Okay, now we will move on to our third and the final lecture in this rheumatology symposium. The topic is classification of dermatomyositis and polymyositis. This lecture will be delivered by Professor Ali Javed, consultant rheumatologist, the Royal London Hospital, Barts Health NHS Trust, London. Over to you, Professor Ali Javed.
Now, I'm going to talk about the classification and diagnosis of dermato and polymyositis, that is the group known as the idiopathic inflammatory myopathies. This is the outline of the talk. I'm going to talk about the classification criteria of the 1975 Bowen and Peter, then move on to the 2017 EULAR ACR classification criteria for adult and juvenile idiopathic inflammatory myopathies and their major subgroups. And the second half of the talk is to talk about the different phenotypes of idiopathic inflammatory myopathies. However, I'm going to start to talk about COVID-19 and muscle injury because it is very topical. As we know, myalgia and fatigue are very common during COVID infections, but evidence for viral myositis is lacking. In Wuhan, 11% of patients had evidence of some form of muscle injury with elevated CK more than 2000 and or muscle pain. And there have been at least 2 case reports of rhabdomyolysis associated with very high CK level of more than 12,000. Now, going back to 1975, when Bowen and Peter proposed these classification criteria, they divided the conditions into primary idiopathic polymyositis and dermatomyositis, dermato and polymyositis associated with neoplasia, and childhood dermato and or polymyositis. And their criteria were as follows: essentially symmetrical proximal muscle weakness plus elevation of muscle enzymes, myopathic picture on the EMG, a positive muscle biopsy, and obviously for those with dermatomyositis, classic dermal signs. So for the diagnosis of PM, you need 3 out of the first 4 criteria, but for the diagnosis of dermatomyositis, you need obviously number 5 plus 3 out of 3 out of the first 4 criteria. Now, the classical triad of EMG changes are depicted here, and you could see there is fibrillation at rest with increased insertional activity, in addition, there is bizarre high frequency repetitive discharges and also some polyphasic potentials of short duration and low amplitude. However, this triad is not diagnostic and is generally present in only 40% of patients with these conditions, and 10% of these patients may have a normal EMG result. Now, the muscle biopsy, there may be a difference between polymyositis and dermatomyositis. In polymyositis, there is mainly infiltration of CD8 lymphocytes, while in dermatomyositis, there's mainly CD4 T lymphocytes with B cells and plasmacytoid dendritic cells in perivascular and perifascicular atrophy. And you can see in this slide, for example, you can see the amount of fibrous tissue separating the bundles of myofibrils because of the damage to the muscles, and the muscle fibrils have become atrophic. In inclusion body myositis, you see these vacuoles, which filled with and deposits of beta amyloid and ubiquitin. The problem with the muscle biopsy is there are many overlap. There is, for example, a patient, for example, who has a muscle biopsy typical of polymyositis, but he also has the rash of dermatomyositis. And you could see, for example, a patient who has no rashes, yet he has a typical muscle biopsy of dermatomyositis. So in fact, these are really challenging factors in a way, making an accurate diagnosis in some of these patients very difficult. So really this, in a way, histopathological classification is not without its faults. Using MRI scans is very helpful, because you can see, for example, in this patient, in this child, you can see the inflammation in the muscle, which is showing white on the MRI scan. Now, the limitation of the Bowen and Peter criteria is, as we said, they do not clearly specify how to exclude other forms of myopathy, and they misclassify inclusion body myositis as a form of polymyositis. They also could classify the muscular dystrophies with a degree of inflammation as myositis, and they shouldn't be. And the criteria are really not defined explicitly. This led to the classification criteria being changed by both EULAR and the American College of Rheumatology, and they published them in 2017. Now, with these recommendations, the patients with rashes, and they chose heliotrope rash, Gottlin's papules, and/or Gottlin signs, are accurately classified in these criteria, in the classification criteria, without including muscle biopsy data. And for patients without these skin manifestations, a muscle biopsy is recommended, while for patients with dermatomyositis without muscle involvement, a skin biopsy is recommended. Although these classification criteria are mainly used really for research purposes, they are in a way useful for us to help us in diagnose these conditions using some of their recommendations. And they use it, the classification criteria is really rather complex, because each criteria has been given a number, and this is unique depending upon the sensitivity and the specificity. And generally, a certain aggregate will classify the patient as having idiopathic inflammatory myositis, and the cutoff percentage is 55%. And if we look at the criteria, no one is expected to remember those, but you can see most of that, obviously the age is important, but when you look at muscle weakness, more importantly is the weakness of the flexor muscles. And you can see they score higher, for example, than objective symmetrical weakness in the upper limbs or in the pelvic girdles. So in a way, the neck flexor weakness is very significant and important. And if you look at the skin manifestations, in fact, they score very highly. Look at the heliotrope rash, 3.1, the Gottman's papules, 2.1, the Gottman sign, 3.3 without a biopsy, and similar but higher figures for those with muscle biopsy. And you can see this, the heliotrope rash, it is purple or lilac color or erythematous patches, usually associated with edema over the eyelids. The difference between Gottman sign and Gottman papules, the Gottman sign is a macular erythema over the extensor surfaces of the knuckles and the proximal interpharyngeal joints, while the papules, they are palpable because they are papules, not macules, and in the Gottman sign. However, they chose these three dermal manifestations, but there are other dermal manifestations of dermatomyositis. For example, the malar-like rash, the rash over the V-neck area of the chest, the shoal sign, which is the erythema on the upper half of the back, and the Holster sign over just below the greater side. This is an important sign to look for, the cuticular overgrowth with periangular erythema, and you could see the dilated blood vessels here. This is an important sign to look for. The mechanic hands are well known. They are hyperkeratotic areas with fissuring and scaling, and associated with telangiectasia, and also the radial side of the index finger is always affected. Now, going back to the criteria, the other criterion that really scores the most is the anti-Jo1 antibodies, but you could see even with the muscle biopsy, the score, apart from the rimmed vacuoles, which scores 3.1, do not score as much. So as I said, the recommendation is for definite idiopathic inflammatory myositis. It corresponds to a probability of more than 90% and a total aggregate score of 7.5 or more. And as I said, there is those with possible, the score is 50% or below, and with a minimum score of 5.1 without biopsy and 6.5 with biopsies. Now, there is in fact a classification in three which is useful. Essentially, if the patient is under 18 with the rash, then they are classified as juvenile dermatomyositis. If they are older with the rashes plus the objective muscle weakness, then they are classed as dermatomyositis. But in the absence of muscle weakness, they are classed as amyopathic dermatomyositis. And if they don't have the rashes with a specific biopsy, then they may end up being classed as inclusion body myositis and so on. Now, let's talk about the different phenotypes, because I think that is important from a clinical point of view. There are at least different phenotypes. Talk about the individual ones. First one is the antisynthetase syndrome phenotype. Essentially, these patients obviously have antisynthetase antibodies, and the classic phenotype, whether they have polymyositis or dermatomyositis, they generally have interstitial lung disease. arthritis, fever, Raynaud's phenomenon, and mechanic hands, as shown here in the slide. But there are atypical phenotypes. For example, we could see patients with antisynthetase antibodies with pulmonary disease without muscle involvement. And sometimes you just see the myositis without the lung manifestations or the other features. And the most important antisynthetase antibodies are the first three. Obviously, JO1 is the classic one, described back in 1981. And the other two, the anti-PL7 and PL12, are really important. If they are positive, they generally signify that the patient will develop severe interstitial lung disease. The others are much rarer. Now, with the statin-induced myopathy is important to talk about because we know that more than 10% of patients who take statins will complain of muscle pain, cramping, tenderness, or weakness, usually affect the pectoral muscles or the quadriceps muscles, the biceps, the abdominal and back muscles, the core stability muscles. And the CPK, the muscle enzymes, they could be normal, but they could be more than 10 times the upper limit of normal. And a small number of patients do develop an immune-mediated necrotizing myopathy, and this is usually associated with antibodies to the HMG-CoA reductase enzyme, and they do respond to vigorous immunosuppressive therapy. Now, this condition, the immune-mediated necrotizing myopathy, as we said, has been reported with statin therapy, and it's exceptionally rare, occurring in 2 to 3 out of every 100,000 patients taking statins. Although the onset of the weakness could be very soon after starting therapy, however, some patients have been taking the statins for years before they develop the symptoms. And they could be really very simple muscle pain or difficulty in standing up from a chair or climbing stairs or lifting heavy objects. And generally the weakness persists or worsens even if the statin therapy is discontinued. Some, and that is the majority of patients, only have mild to moderate weakness, and severe weakness is really rare. Although the myopathy mainly affects the skeletal muscles, but mild joint pain is very common in these patients, and they may develop rashes as well. And this is how you make the diagnosis. You have to have the symmetrical proximal muscle weakness, very high CK, the antibodies, myopathic EMG, on the MRI scan, muscle edema, but the biopsy is very specific. And unlike polymyositis or dermatomyositis, it is mainly, the main feature is the number of macrophages infiltrating the muscles. And you could see for example, here the fiber necrosis, and here you could see some macrophages essentially engulfing myocytes. And if with using special stain, you could see that, for example, in this upper box, the immunostain is against CD68, which is macrophages, and you could see it's full of macrophages, while immunostaining it against CD8, which is cytotoxic T cells. There's very few T cells and very few B cells. This is immunostained against CD20, which is a B cell marker. So it has a specific biopsy. The macrophages are the predominant type of inflammation. And the patients, 92% of those who are positive for these antibodies, and they tend to be older, above the age of 50, when they first started taking the statins. If the antibodies are detected after statin exposure, then this strongly support the diagnosis of an autoimmune process. Those who do not have the antibodies do not have this condition. Now, the antibodies may also be present with autoimmune myopathy who have never been prescribed statin. These patients tend to be younger patients, and they the myopathy tend to be less responsive to therapy than statin-exposed patients. Now, in the majority of these patients, they are usually eaters of red yeast rice, which contain a statin-like condition, and in fact, it does lower the lipids, very similar to statin, and in fact, eating red yeast rice also causes myalgia, muscle pain, muscle tenderness in some patients. And the patients who get this condition who have not taken statins usually have been eating red yeast rice. Now, another phenotype which really you must remember is the Nd5 Associated Dermatomyositis. The Nd5 stands for melanoma differentiating associated gene 5. And typically these patients have the Gottran's papules, but they tend to ulcerate, and you could see them not only on the knuckles, but you could see them on the digital pulps and on nail falls and over the elbows. They also could get alopecia, oral ulcers, they can get arthritis, and generally the myositis is not severe in these patients. These patients have a very high risk of interstitial lung disease, which is rapidly progressive. And this is why it's very important to recognize the skin manifestation of these conditions so that treatment could be started early. And generally, these patients do not present to the rheumatologist, but they present to the general physicians or respiratory physicians, and overlooking these cutaneous signs may lead to delay in diagnosis. Now, there is patients who carry the anti-NXP2 antibodies may develop calcinosis. And I've seen two patients. This is a 60-year-old African woman with amyopathic dermatomyopathic dermatomyositis. And you could see these calcification is in the subcutaneous tissue where she has had the extensive erythrodermic rash. And in fact, you could percuss these areas because it is so hard. And this condition is not related to delay in diagnosis and treatment in contrast to other manifestations of these conditions. This is another Bangladeshi woman. She was 31 when this slide was taken, and she had JO1 positive dermatomyositis, was treated with cyclophosphamide and currently on methotrexate and prednisolone, and she developed these tumoral calcification within the muscles affected. You can see in the muscles around the pelvic girdle, and she had similar changes around the shoulder girdles. They both had the antibodies. Cancer-associated myositis is another subgroup. Malignancy could be diagnosed in up to a third of patients with dermato or polymyositis. And generally, it is diagnosed in about 58% within the first year. The commonest malignancy is ovarian, followed by lung cancer, GI, and breast. But I have even seen it with carcinoma of the vulva in a patient who is 92 years old. Generally, patients with dermatomyositis do have a higher risk of malignancy, even 5 years after the diagnosis is made. And these antibody NXP2 and anti-SAE and anti-TIF1Y antibodies tend to be associated with the diagnosis of cancer, but not in children or in juveniles under the age of 18, because anti-TIF antibody does occur in patients with juvenile dermatomyositis, and generally have severe cutaneous manifestations, but they are not associated with cancers in the under. Another antibody, anti-SAE antibody, which is anti-small ubiquitin-like modifier activating enzyme antibodies, they are interesting because they usually present with amyopathic dermatomyositis with extensive erythrodermic rash. So I think be alert to that. And although at the beginning they may have no muscle involvement, but sometimes severe myositis, especially associated with severe dysphagia, may occur. Other phenotypes, those with SRP antibodies, generally this is a good news antibody. They are associated with very good prognosis, while those with MI2 antibodies, they tend to have a very good prognosis. Sorry, the one with anti-SRP antibodies have very poor outcome, while those with anti-MI2 antibodies, they tend to generally have good outcome. So in summary, the patients with pathognomonic skin rashes, such as heliotrope rash, Cotrin sign, or Cotrin patches of both the juvenile or the adult type of dermatomyositis are accurately classified with the ULR, within the ULR ICR classification criteria without including muscle biopsy data. But for those patients without these skin manifestations, a muscle biopsy is recommended. And for dermatomyositis patients without muscle involvement, a skin biopsy is recommended. It's also important to identify other clinical phenotypes, especially Nd5 dermatomyositis early, as the outcome may be very poor. And thank you very much.
Thank you very much, Professor Ali Javed. Unfortunately, due to time constraint, we are not able to allow any questions. Again, I would like to thank you for that excellent presentation. Thank you, Professor Ali Javed.
Thank you very much.
To conclude this rheumatology symposium, I would like to hand over to my co-chairperson, Dr. Duminda Munidasan.
Yeah, I would like to thank all delegates who joined in this rheumatology session. And special thank to Dr. Amal Tilakaratna, concerned rheumatologist, for putting the college in touch with two eminent speakers from the Dudley Trust. And thank you, Dr. Adrian, Dr. Rao, and Professor Ali Jawad for joining us. So as soon as the COVID permits us, we look forward to seeing you in Sri Lanka. Hope that day will come very soon. Thank you very much.